Good evening, everyone, and welcome to tonight's Woo You event with Dr. Melissa Barnett. She's going to be talking on how to heal when you can't feel, Neurotrophic Keratitis Update. I love that title. I'll be your host tonight. My name is Dr. Ariel Sorenzi. All right, it's my pleasure to introduce our speaker, even though I know most of you have probably heard her speak at least once. She's a world-renowned key opinion leader recognized for expertise in specialty and scleral lenses, dry eye disease, keratoconus, and presbyopia. She has authored more than 275 articles and books, delivered over 350 lectures, is a board member and founding member of the Intrepid Eye Society, and serves on several industry boards. Her work has been featured in numerous medical journals, professional magazines, as well as consumer publications such as Bloomberg, Prevention Magazine, and Good Housekeeping. So recently also started a really awesome podcast that I've been loving hearing called the Clearly KC podcast. So please be sure to tune into that. And she has been previously awarded the Scleral Lens Practitioner of the Year Award from the Scleral Lens Education Society, the inaugural Thea Award for Excellence for Mentoring Women in Optometry, and was granted the Most Influential Women in Optical from Vision Monday. And then here are financial disclosures, and all of which have been mitigated. And I'll have you take it from here. Thank you so much for blessing us with your presence tonight.
Oh, well, thank you so much for the kind introduction. And thank you all for joining. This is a great topic. And I really appreciate you taking the time out of your busy day to learn a little bit more about neurotrophic keratitis. So for those of you who were in clinic today and saw patients, I bet that you saw at least one or two patients with NK. I really want to thank all of my colleagues for their contributions to this lecture. I couldn't have done it without them. Really want to thank them, and they are recognized on the individual slides and also in the lecture as well. So let's start with this one. So this is a real world case of unresponsive dry eye. And that's what we're going to see a lot of. Is it dry eye or is it NK? And hopefully you'll get some clarity with this lecture tonight. 50-year-old female who comes in complaining of blurry and fluctuating vision, little scratchy sensation in both eyes, right more than left, and photophobia or sensitivity to light. Had a history of LASIK in both eyes about 21 months ago, with a flap enhancement in the right eye as well. So, in your mind, think there's a history of refractive surgery and had additional surgery in that right eye. No history of dry eye. The symptoms occurred after LASIK and was diagnosed with dry eye at that time. History of soft contact lens wear for many, many years. Insulin-dependent diabetic for about 10 years, not well controlled. And tried different medications, some over-the-counter products. So when we talk about artificial tears, we want to know what type. Are they preserved? Are they not preserved? Are they in a bottle? What is that preservative? It's been such a time in artificial tears lately, and with all the recalls and all the unfortunate damage that they've caused. So even more now than ever, I have patients coming in asking, is this artificial tear safe? Can I use it? Patient said none of these things help. Try some other artificial tears 12 to 15 times a day. That's too much because that is going to disturb that natural tear film homeostasis, or that beautiful balance that we have on the ocular surface. Patient doesn't recall being prescribed any other immunomodulators or other topical medications and hasn't tried anything else like warm compresses or eyelid hygiene. So is this dry eye or is it something else? Vision is reduced in each eye, 20/40 in the right, 20/40 -2 in the left, reduced tear breakup time in each eye. And you can see meibomian gland dysfunction. There's no lissamine green stain on the conjunctiva, but the cornea does have 2 to 3 plus PEK in that central flap zone and 2 plus PEK in the central flap on the left eye as well. Now, these subepithelial opacities did pick up the fluorescein staining. So looking back here to TFOS DEWS 2, and we have learned a lot from 2017, and DEWS 3 is currently being worked on right now. But we have the presenting patient. We have the patient who's symptomatic, saying my eyes are dry, they're irritating, fluctuating vision is actually my favorite. Um, Symptom of dry eye. And we have those who are asymptomatic. So those who say, my eyes feel fine. And then you look at them and see corneal staining. You might be checking corneal sensitivity. There's a lack of corneal sensation. So we learn from DEWS 2 that we have neurotrophic conditions with that dysfunctional sensation. And it's a little bit different, or quite different actually, than your standard dry eye. We also learned that dry eye disease is mixed mechanism. So we have evaporative component in so many of our patients. We have that aqueous deficient component, and oftentimes they overlap. So even in my severe dry eye patients who have autoimmune disease like Sjogren's, it's oftentimes a mixed mechanism condition. So when we're evaluating our patients, there are many things that we can be looking at. We want to differentiate. Is this a contact lens related dry eye? Any sort of soft contact lens separates the tear film into that pre and post lens tear film. Is it exposure? I like to look at all of my patients, and first of all, I look at them across the room. I look for any, say, asymmetry of their eyelids. I look for their face. Are there any signs of rosacea? Looking at their hands, is there any rheumatoid arthritis, for example? But then diving into the slit lamp, I have all of my patients close their eyes. So I'm looking for things like Demodex blepharitis, lag ophthalmos, incomplete eyelid closure. And I want to know, is there any exposure? And you can ask your patient, do your eyes feel more dry in the morning? Or do they feel more dry in the afternoon? Or does it not matter the time of day that your eyes feel dry? We also have topical medications. So many medications have preservatives. They can really affect the ocular surface. We have systemic medications. Right now in Northern California, it is so windy outside, and it's like the worst allergy time. It is absolutely awful. So many of my patients are on oral antihistamines right now because of this wind and all the allergies and all the pollen. So could it be like an oral medication that is drying out the eyes? That is very common too. Eye rubbing, we want to avoid eye rubbing in everyone. I had a patient today who said, so when can I rub my eyes? And I said, never. You can never, ever, ever rub your eyes. And we don't want to have any eye rubbing. Of course, we have other options that can help with that. Limbal stem cell deficiency, we have the pannus, neovascularization. Peripherally, that can masquerade NK as well, and any sort of radiation keratopathy. So let's talk about NK. So NK is neurotrophic keratitis, otherwise known as NK, which I'll be saying a lot tonight, is a degenerative disease characterized by a corneal sensitivity reduction. So if there's anything that you take home, if you're doing your laundry right now, if you're not listening, the one thing I want you to learn is to be checking corneal sensitivity. It's very, very important to check corneal sensitivity and prior to any anesthetic eye drops. And thank you all for listening. We have the spontaneous epithelial breakdown. So the epithelium just spontaneously breaks down. We have impaired corneal healing. So then we can have corneal ulceration and melting and perforation, which we never ever want to get to. The corneal epithelial cells are actually really unique. So the tear film and the homeostasis and that natural balance of the tear film is amazing. And then we have these epithelial cells that help with corneal integrity and the function by the chronic replenishment of the epithelial cells. We know the cells at the limbus divide asymmetrically and give additional stem cells, and epithelial cells actually migrate out of the limbus. And these corneal epithelial cells and keratocytes regulate the survival, differentiation, and maturation of the nerve fibers. They release neurotrophins. I always think of Pac-Man. They release neurotrophins, just think Pac-Man, and growth factors as well. So in a healthy cornea, we know that a healthy cornea is avascular. It's very sensitive to pain, to things in the eyes. Corneal sensitivity nerves come from the ophthalmic branch of the fifth cranial nerve, and then the trigeminal nerve bundles, and hopefully you can see this here, uh, go into the corneal stroma and at the corneal scleral limbus, and they lose the myosin sheaths, which is why the cornea is clear. And corneal nerves are really sensitive. So they react to injury at the ocular surface. They regulate pain and irritation. I had a patient yesterday with a corneal foreign body, and she's like, yeah, my eye is so irritated right here. And I said, don't worry, after removal, she said, wow, my eye feels so much better, which is fantastic. And we know that blinking is so important, that natural blink of that ocular surface. Now, these nerves release the neuromediators and provide that nutritional support to the cornea. And we want to maintain the cornea. We want to keep the cornea intact. So that's why we really want to be talking about the importance of blinking, the importance of that tear film homeostasis, and preventing epithelial breakdown and eventually loss of vision, potentially. But there are many different mechanisms that are altered with damaged corneal nerves and can lead to impairment of the renewal of the cornea and causes reduced tear formation. So here you can see that dynamic interplay between the nerves, the epithelial cells, the keratocytes, the lacrimal gland, to maintain that beautiful corneal homeostasis or natural balance of the cornea. So we have the corneal sensory nerves. We have the lacrimal gland that, of course, plays a role here too to produce that rich tear film. And we want to have a good blink, a natural blink reflex to protect the ocular surface as well. Now, here's a very important few slides coming up because what I've learned about doing a lot of research into NK and studying it is that there's so many things associated with NK, and then I see it in my patients as well. So when in doubt, think herpetic. So it can always be a herpetic cause. We want to rule out herpes or a history of herpes. Do you have a past herpetic infection at all? Of course, any sort of corneal dystrophy like lattice dystrophy or granular dystrophy. A big one in my practice is contact lens wear and abuse. So those who sleep in their contacts, they don't replace their contact lenses, those are at risk for NK. So if you have a patient with any of these etiologies, it's important that we check corneal sensitivity. Any history of past ocular surgery, so cataract surgery, even years and years ago, retinal detachment repair, glaucoma surgery, refractive surgery, corneal cross-linking, any surgery is actually associated with NK. So we do want to be checking corneal sensitivity in these patients. Any sort of toxic substances like BAK in eye drops, glaucoma medications, artificial tears, many of our glaucoma medications have BAK, which can lead to toxicity on the ocular surface. Of course, any sort of CNS disorder or stroke or neurosurgical procedures for acoustic neuroma or trigeminal neuralgia, all of these patients are at risk for NK. Now, one that I'll share in just a little bit in this lecture is a patient of mine who's diabetic, and that was sort of a light bulb moment, like, wow, I need to be looking for NK in all of my patients who have diabetes. So now I'm checking for corneal sensitivity, and I'll share that case coming up. In other countries, much more common than here in the US, leprosy, vitamin A deficiency can be at risk for NK. MS is an important one, so we want to be checking corneal sensitivity. And dry eye. So chronic ocular surface injury or inflammation, chronic dry eye disease, which many of us have, many patients who have dry eye in our practice, we do want to be evaluating for neurotrophic keratitis. So if you look at all these patients, you can see that there are so many different patients that could be at risk for NK. There are so many of our patients that you might think, well, is this dry eye or is it NK? So we have so many patients that we can be checking corneal sensitivity on. We have a few more etiologies here associated with NK, genetic etiologies as well. So any sort of damage to the corneal nerve can disrupt that corneal homeostasis and can lead to NK. So here you can see the impairment of the nourishment of the ocular surface. It alters the cornea, impairs corneal healing. And when I talk to my patients with diabetes, those that have other trouble healing, say with feet and things like that, we can say it's the same thing on the cornea, on the front part of your eyes. And I have many patients that have this spontaneous corneal epithelial breakdown. And I always feel like my role is to maintain the corneal epithelium. So making sure that it does not break down and then lead to many different problems down the road. One thing I've also learned is that NK can be highly variable. So in early NK, and I'll go over staging in just a bit, but we can have very minimal corneal staining. We can have coalesced corneal staining, but we can also get a persistent epithelial defect. You can see the image here. On the right, this is my patient who has GVHD. She's monocular, has one eye, and she kind of goes between that epithelial defect where her epithelium is breaking down and then her epithelium is healing up again. So we want to make sure that the epithelium is in that beautiful natural homeostasis as much as possible. We'll talk about scleral lenses coming up too, and some of you know how much I love scleral lenses. So diagnosing NK, it's really the history. So I went over all these different etiologies of when a patient might have NK. I want to ask for any history of herpetic infection, any history of ocular surgery, anything. Are eye drops used? Are there any preservatives in that drops? Is a patient a contact lens wearer, or is there a history of contact lens wear? So here are some of the main things that we can ask all of our patients, and looking into other things if there's not a history, like could it be MS? Could it be chronic ocular surface disease? These are all things that we want to ask in the history. Herpes, herpes, herpes. I keep talking about it, but a third of NK patients actually have herpes or herpetic infections. We have patients who have simplex, 25.7%, and zoster, 6.5%. So if you're not sure, think herpetic. And symptoms in our patients with NK, it's that stain without pain. So you're looking at the cornea, you're looking at the conjunctiva, you're seeing some staining, and the patient is saying, nope, everything's fine. My eyes feel fine, because it's that disconnect of the signs and the symptoms. In some of my patients, it's really the blurry vision why they come in. Yes, my vision is blurry because there's staining on the cornea. There's that lack of corneal homeostasis, and there's not any pain or irritation or anything like that. Especially when we have patients with severe punctate epithelial keratopathy or even an epithelial defect, they really aren't having symptoms. They might say, no, my eyes really feel okay. So that's why it's important to check for corneal anesthesia and check for a lack of corneal sensation. The location of the staining is very important. So this is a publication that was done and things for the images as well. But NK has a more central or diffuse corneal staining in general compared to inferior corneal staining and conjunctival staining that's more consistent with dry eye disease. So say a patient comes in and has sort of diffuse staining. I had a patient who I saw yesterday in one eye with diffuse corneal staining, and that's sort of a light bulb, like, does this patient have NK? Her sensation in the left eye with the diffuse staining was reduced compared to the sensation in the right eye without the diffuse corneal staining. There are different ways that we can check for blink. So all of us on digital devices, we don't blink as much as we should, but a normal blink rate, maybe 16 to 18 times a minute, can be reduced with NK. The reduction in the blink can be altered either in one eye or in two eyes, and be aware of incomplete blinks. And we all need to blink. Okay, everyone blink right now. Blink, myself included, right? We're on digital devices so often. Blink, blink, blink. But we want to make sure that we don't have any incomplete blinks that can lead to a breakdown of that corneal surface. Now you can do other things as well. We can use hyperosmolar drops that can cause a reflex eyelid squinting. And the more hyperosmolar the solution, the stronger the blink reflex. So we can evaluate NK in a different way as well. If you have this method in your practice, a non-contact gas aesthesiometer, it stimulates the cornea with calibrated air or gas emission. It's not really that common in clinical practice, maybe more in research, but we can check things like the mechanical components, the temperature, and the chemical components as well. Cochet-Bonnet is another way to check corneal sensitivity, and this is a filament that is on the surface of the eye, as you can see. We're looking for the length of the filament until the patient reacts and blinks. The shorter the length, the greater pressure that's needed, and the sensitivity is quantified by that filament length. So we want to check the central quadrant. We can check for corneal sensitivity centrally, superior, inferiorly, nasal, and temporally as well. There are other ways of checking corneal sensitivity, so using a cotton thread. Now, what I've learned is that we want to use gloves when we're taking off this cotton thread because we don't want to have any bacteria or debris on our hands and cause an infection on the surface. We want to check the sensation between the two different eyes. And another way of doing this is just the edge of a tissue. And then my preferred option is actually unwaxed dental floss because you can break off the dental floss and have a very prescribed length of that dental floss and use it now, not non-minty, non-cinnamon dental floss, but using unwaxed dental floss is really easy to have in your practice. Another way of testing is in vivo confocal microscopy. So we can check the density of the corneal nerves. So here you can see on the left-hand picture here, the subbasal nerve plexus in a normal cornea. And then the lower right, we have the decreased density of a subbasal nerve plexus. So this is a very accurate tool, something that a lot of us don't have in clinical practice. So getting back to the patient. So the patient, bringing it back clinically here. So the patient with unresponsive dry eye who had LASIK, history of soft contact lens wear, diabetic patient who tried a bunch of things, including artificial tears and was using artificial tears many, many times a day. And the reduced vision, reduced tear breakup, and all of this, again, the subepithelial opacities picked up that corneal stain. So the patient that comes in, by using the LipiView, this was really helpful in checking osmolarity. Now, the normal osmolarity, 308, checking corneal sensitivity with the cotton wisp, and there was no prior anesthesia for this patient, and there was reduced sensitivity noted, so -2, so a reduction in sensitivity on the cornea, both eyes. So this patient was diagnosed with mild NK. Confocal microscopy was ordered. If you have the opportunity to collaborate or send a patient out, if you don't have this instrumentation, that's fantastic. If you can't do that, that's okay as well. Still, please check corneal sensitivity. And the patient was educated on all the risk factors for NK. The patient's diabetic, has had ocular surgery, is using artificial tears very often, chronic ocular surface disease. And the patient was managed with autologous serum, 50%, using that 4 times a day for 12 months, added in some warm compresses. I tend to like a commercial warm compress, preservative-free artificial tears. The patient noticed a mild improvement after 6 months, so added oxervate at that time. And here you can see the baseline. These are kind of really cool images here of the cornea. And getting back to the patient here, there was an improvement in corneal staining and vision with 6 months of autologous serum drops. Vision was a little bit improved on that left eye, but still central PEK. Any sort of corneal staining on the cornea, especially centrally, will affect vision. Adding oxyrvate at the end of 8 weeks, you can see the improvement, not only in vision, going from 20/30 to 20/20, say in that left eye, the cornea on the left eye is clear compared to that diffuse staining. So that is a significant improvement there. And then a second round of oxyrvate was done for the right eye only, because the right eye was 20/30 with 2 plus central PEK. With that second round, I think this case is pretty incredible, thanks to Scott Hausworth, but 20/15 -1 vision on the right, 20/15 on the left, clear cornea. So think about, wow, going from 20/40 in each eye to 20/15. That is a significant improvement, and the cornea is absolutely clear without any signs of corneal staining. So let's look at all the different options that we have for NK. And there are a lot of different options. I think it is the most important thing to be checking corneal sensitivity, starting with things that are easy, removing any sort of offending agents, removing preservatives, for example, with BAK, switching to preservative-free artificial tears. And it's wonderful that we have multi-dose preservative-free artificial tears. We do want to talk about artificial tears and replacing them, especially those that are single use and there's more drops in there than can be used at one time. So making sure that those are replaced. Those that are in bottles, once they're opened, using whatever prescribed recommendation replacement that is, because it could be 3 months, it could be 4 months, etc. You want to get rid of that. We can add in oral doxycycline. This is, again, stage 1. Now we move into stage 2, NK. And we have all these options, such as scleral lenses, bandage contact lenses. I've become, gosh, such a huge fan. Sometimes I forget about soft bandage contact lenses. And lately, they've just been so helpful for corneal abrasions and epithelial defects. It's a really great option there. Punctal plugs, another wonderful option, and something that some of us don't use enough. And then moving into stage 3. So I want to prevent any sort of surgical procedure that's needed for our patients. My patients really don't like having a tarsorrhaphy or having their eyelid sewn shut, and then it's really hard to take that down when doing something like fitting them with a scleral lens. We know the risks associated with corneal transplantation and like to avoid that at all times as well. But the great news is that we have oxyrvate or synergimin, which can really help heal the cornea and get the patient back to that homeostasis of the cornea. This is the Mackey classification that was used in the US trial. Here we can see stage 1 NK. So this is mild. We have epithelial changes, but no epithelial defect. The important thing here about stage 1 is that we have corneal hypoesthesia or anesthesia in more than one quadrant. So we can check corneal sensitivity with your favorite method, maybe some dental floss. You can check it centrally. You can check it first central, then superior, inferior, nasal, temporal, or checking it in certain quadrants at more than one to diagnose stage 1 NK. Stage 2 NK, we have a persistent epithelial defect, but no sort of stromal defects. And of the stroma of the cornea, Descemet's membrane folds, but no stromal loss or defect. And hopefully we'll never get to stage 3, severe, where we have stromal thinning or perforation. We have corneal hypoesthesia or anesthesia greater than one quadrant, but the corneal ulcer, stromal melting, and the potential for perforation of the cornea as well. We know that NK is a progressive degenerative corneal disease. So like many other diseases, like dry eye disease, it is progressive. and it is a chronic condition as well. So in the healthy cornea, looking at NK here, in stage 1, you can see the disruption of the corneal epithelium here with central corneal staining. Stage 2, we have the presence of an epithelial defect or a divot there in the cornea. And stage 3, you can see the corneal ulcer. So let's talk a little bit about autologous serum drops. So definitely a good option. They're non-preserved, non-allergenic drops that are taken from the blood serum. Concentrations range from 20 to 100%. In this case, we used 50%. And there are various components in autologous serum drops that can be very helpful for the proliferation and differentiation of the corneal epithelium. Coordination has the use of autologous serum drops used 6 to 8 times a day for the first month, and then tapering to 4 times a day. So here you can see the process. The patient's blood is taken, it's centrifuged down, separated, diluted, and then refrigerated or even frozen, the remainder of the supply of serum drop. Antibiotic is a great option. We can have dehydrated, we have sutureless versions, cryopreserved, and 75% of patients with NK had a cornea that re-epithelialized in 16 days. The average time of re-epithelialization is 21 days. Of course, scleral lenses are a great option for NK as well. Scleral lenses are large diameter, gas permeable lenses. They go over the cornea, land on the scleral conjunctiva. We can use a larger diameter lens filled with fluid. That fluid bathes the cornea during the time in the bowl of the lens. It protects and supports the ocular surface from the external environment, prevents any sort of even minimal trauma. Scleral lenses are very stable with minimal movement, and they promote corneal healing and improve comfort and also the quality of life. When we're talking about scleral lenses for ocular surface disease, there is a risk-benefit ratio. It's unlike, say, scleral lenses for irregular corneas, where there's still a risk and benefit, but we know that scleral lenses for corneal irregularity is really going to help the vision by smoothing out any sort of irregularity with that post-lens fluid reservoir. Now, scleral lenses can be used for ocular surface disease, even moderate dry eye. Here we're talking about NK, but even severe ocular surface disease very well. We want to make sure that we are doing all best practices to prevent microbial keratitis. We want to monitor our patients very closely, especially for those with epithelial defects. We can use a lens during the day, a lens during the night. We can see our patient every single day to make sure that the epithelial defect is resolved. And we also want to be aware of any sort of systemic conditions that are underlying, and also if there is an acute response or a flare of any of those conditions. So, for example, does the patient have something like Sjogren's or rheumatoid arthritis with a flare? Do they have any sort of GVHD or severe allergic response with a flare, a systemic flare as well? And using an antibiotic in both the lens, the scleral lens as prophylaxis is a great option to prevent MK or microbial keratitis. Scleral lenses can be used in NK for short term, they can be used for long term. Of course, scleral lenses can correct vision as well, so it is a helpful option. Here you can see a few patients with NK with scleral lens wear. And thanks to Alan Kwok, here are some nice images of healed epithelial defects with scleral lens wear as well. So there is a protocol for scleral lenses about how to use scleral lenses with persistent epithelial defects. I find that monitoring and collaborating with my corneal specialist is really helpful. Oftentimes it's other specialists as well, but if there is an epithelial defect, we're working together to heal that cornea and monitoring the patient extremely closely. So this is my case. This is my eye-opening moment of the case that really got me thinking about NK. So let me share with you. This is a 74-year-old Hispanic male who is seen same day for a sudden onset of vision changes. He described them like things look like raindrops on a window. My patient had a long-standing history of diabetes, well controlled. Cataract surgery was done in both eyes a year before, and also had epiretinal membrane surgery in the left eye, a history of chronic dry eye disease. Now, this patient was not a non-contact lens wearer, and that's important as well. Patient was on Xiidra twice a day, used preservative-free artificial tears as needed, and was taking oral omega fatty acids. So with the slit lamp exam, meibomian gland dysfunction, both eyes. On the right eye, conjunctiva was clear. The left eye, there was diffuse injection. Cornea on the right had trace inferior PK. The left, as you can see here, has a 2 millimeter epithelial defect with diffuse corneal staining. The patient had a really red eye, and you can see the diffuse edema as well of the cornea. The cataract surgery went well. The lens implants were fine. The dilated retinal exam was fine as well, as all normal. So I was concerned about this patient. I was especially concerned because diabetic patient, non-contact lens wearer, comes in with an epithelial defect. And I said, wow, what is this? Sent the patient off for various cultures with the corneal specialist, the fungal culture, no growth, that everything was fine. So all of the cultures on the cornea were normal. Corneal sensitivity checked with a cotton wisp, demonstrated anesthesia in that left eye, and the patient was diagnosed with stage 2 NK. Now, the thing that I love about this patient is he was diagnosed with NK. He was eventually prescribed Oxervate. His cornea healed up. He came to me. I fit him with a scleral lens in the left eye, new to contact lenses, never wore contacts before. He did great. And one thing that I like to tell my patients, especially those with NK, is that if you have any redness of your eye, if you have any vision changes, because oftentimes they're not feeling anything, they don't feel a sensation. But if their eye looks red, or if someone looks at them to tell them that their eye is red, to come on in. And this patient has come in, he's actually come in a few times where fortunately his cornea was intact. There was no epithelial defect, but I'd rather see my patient and make sure that their cornea is doing fine than for them to have an epithelial defect and the cornea breaking down. They're also moving on, there are also surgical treatments for NK. So a chorosorrhaphy can be done, so sewing the eyelid shut, either in one specific location, such as laterally, can use it with a bandaged contact lens, can do a conjunctival flap, induce ptosis with something like a neurotoxin, add in a gold weight as well. All of these, of course, can impact a scleral lens fit. Using punctal occlusion is something that can be helpful. Corneal neurotization, it can also be done for NK. This is helpful to restore corneal sensitivity, but it is an invasive procedure using a nerve graft as a donor source. And it's amazing actually seeing how this surgery is done. But of course, it is a little bit more of an invasive procedure. And then we do have an option that was approved in August of 2018, and that is synergimin, otherwise known as Oxervate, which is structurally identical to human nerve growth factor protein that's found in ocular tissues. So this is a naturally occurring neurotrophin that is responsible for the differentiation, growth, and maintenance of neurons. Here you can see the studies, and looking at the studies over 8 weeks using the drops 6 times a day. And I love this slide because it really shows how this works so well. Again, we want to make sure that the cornea is clear. without any epithelial defect nor staining. In the baseline, you can see the epithelial defects here as we go from left to right. Week 4, there's improvement. Week 6, even more improvement. And week 8, even more improvement. So there's complete corneal healing. The entire cornea is healed. No staining, no epi defect. And that is pretty impressive looking with time. There's complete healing of the cornea into up to 72% of patients at week 8. Now, one thing I do think it's important is that this is a 6-time-a-day drop. And so I had a patient recently, and I asked her, who with multiple other health conditions as well, taking multiple other medications. And I asked her, how's it going? How are you doing with the 6 times a day? And she said, thank you so much for asking me that question. No one ever asked me that question. And I said, well, I understand that it's a lot. It is relatively short term, but it's a lot to do. So just having a little bit of empathy with our patients, like, yes, this is something that you're going to have to do. It works extremely well, but knowing that a 6 time a day treatment is can affect quality of life. Getting back to the clinical trials here, 80% of patients had complete healing, were still healed 48 weeks after one 8-week treatment cycle. So getting on to another patient here. So we have a patient who came in for a second opinion, was diagnosed with conjunctivitis, was on ofloxacin, and the systemic history of atrial fibrillation, an ocular history, a history of shingles in the left eye about 20 years ago. So again, just think, always ask if it's herpetic. And I always remind myself of that as well. Patient also had cataract surgery about 10 years ago, had multiple RD repairs. So this patient had multiple surgeries, and vision in the left eye was poor at baseline, even prior to the diagnosis of conjunctivitis, 2400. The vision in the right eye, 2025. So looking at the external exam, there's no signs of lag ophthalmos, no lid defects. Important to avert the eyelids also, making sure that there's no foreign objects. Patient does have moderate blepharitis and maybe some rosacea. The ocular rosacea is so incredibly common, where we see the telangiectatic blood vessels. Then I also like to look at the face to see if there's any facial signs of rosacea and ask if there's any family history of rosacea as well. This patient, looking at slit lamp exam, has a 5.5 by 3 millimeter epithelial defect. You can see the epithelial defect here with the heaped up rolled edges on the defect with the punched out borders. I mean, you can see this epi defect. Patient also has stromal thinning, a diffuse corneal haze, and also has conjunctival injection with no cells or flare in the anterior chamber. Checking with the Q-tip technique, corneal sensitivity, there was severely reduced sensitivity in the left eye, and the patient said it's only about 20 to 25% in the left eye compared to the right eye. So I oftentimes check corneal sensitivity in the more normal eye first, because then my patient can say, oh yes, I feel this. And I like to tell them it might feel like a little tissue, even if it's not a tissue, even if it's a cotton wisp, or a little tickling sensation there on your cornea. So I check the norm first, then versus checking the eye that I'm more concerned about, and then the normal eye, because then a patient might not know what is normal. So getting back to the case here, we have a poorly healing ulcer. Maybe it's a herpetic ulcer. Treatment, long list of treatment here. So all these things that we could do. So compresses, we could try a soft bandage lens, tarsorrhaphy, scleral lens, serum, oxervate. And I'm not saying that one option is better necessarily than the other, but we do have a lot of options. Oh, the most important here being Valtrex, right? To if we're thinking that it's a herpetic infection. So for this patient, kept him on the antibiotic drops and ointment and started with an amniotic membrane, the Procara Plus. 5 days later, the epidefect was a little bit smaller. The Procara was melted, it was replaced. 3 days after that, the epidefect was even more smaller. Then sent for a temporary tarsorrhaphy. 5 days later, the epidefect was slightly smaller. The temporary tarsorrhaphy was still there. And then moving on 6 days later, and then 8 days later, the epidefect was still there. The temporary tarsorrhaphy was still in place, but the cornea is still thinned, and then went on for additional treatment to suture an amniotic membrane and repeat the tarsorrhaphy. So here you can see post-op day 1, it is intact, it went successfully. And then post-op day 9, Oxervate was started 6 times a day that day. And then if we kind of move on to week 5 here, it's stable, continuing the Oxervate, the erythromycin ointment, preservative-free drops. And then moving on even more to week 16. But think about all this time for the patient. Valcyclovir was decreased, erythromycin ointment was stopped, continuing with the preservative-free artificial tears gel ointment, and added in a plug. So one thing is that Oxervate sometimes can take a little time to get. And so starting with one treatment and then also going through the process, prescribing Oxervate at that time is something that has been helpful in our practice. So here you can see some images of the patient, much improvement over time, still corneal staining there. I bring up this slide of all the different artificial tears just to stress the importance of using artificial tears that are preservative-free or that have mild preservatives. We want to make sure that we're not harming the ocular surface with any sort of artificial tears. Now we're going to move on to another patient. So this is a patient who came in saying, I have decreased corneal sensitivity. How many of you have had a patient who comes in saying, I have decreased corneal sensitivity? Patient denies trauma, has been on oral valcyclovir on and off for the last 4 years, uses different lubricant drops and ointments for years, no improvement in vision, says my vision is blurry, my eyes are red, and I have a foreign body sensation in the left eye more than the right eye. So this sort of patient, I like to ask, well, what sort of drops have you been using? And what sort of ointments have you been using? I had a patient this week. I have actually not seen an over-the-counter antibiotic drop that the patient was using occasionally for a long time. I learned something new all the time. Patient comes in with visual acuities, 20/25 in the right, 2100 in the left. Entrance testing was unremarkable. Even with the manifest refraction, vision in the left eye still reduced to 20/60. And here you can see why. So we have central staining, which of course is going to reduce vision. Also have decreased corneal sensitivity in the left eye more than the right eye for this patient. So fortunately, using Oxervate 6 times a day, 8 weeks post-treatment, clear cornea, improved vision for eyes. Here's a study. There were 17 patients in the study. Those that were included had diffuse punctate epitheliopathy by corneal staining, had a central corneal grade of 2 or more on the Oxford scale. Those that were not included in the stage 1 NK had any sort of epithelial defect, any sort of active ocular infection that required treatment, any sort of ocular surgery in the last few months. Those patients, 10 out of 17 patients had mild to moderate discomfort while on this treatment, which did not result in interruption or discontinuation of therapy. Oh, also, all patients had a decreased corneal sensation by checking with either Cochet-Bonnet or swab and were unresponsive to previous therapies. So here you can see the changes in corneal fluorescein staining and best corrected vision following treatment with the oxyrvate. So the corneal staining here on the left, you can see that there's less corneal staining compared to post-treatment compared to baseline. And then the visual acuity, we also see that there is improvement with time. And the visual acuity and the corneal staining, of course, go hand in hand because we have the cornea and the tear film, of course, that's the first refracting surface of the eye. And so if we have even any sort of mild corneal staining, I want to determine, why do we have this corneal staining? Is it dry eye disease? Is it meibomian gland dysfunction? Is it a tear film deficiency? Like, why is there corneal staining? Because we want to address any sort of corneal staining so that the patient does not have a reduction in vision. So here you can see some really nice pictures. We have a pre-treatment photo versus a post-treatment photo, much improvement. Post-treatment, of course, we want to be evaluating our patients, staining them so we can evaluate the corneal surface. And here we can see the nerve density comparison as well. So looking post-treatment improvement in all of the groups over time. And here's some really kind of cool nerve photos so we can see that we do have an improvement in the nerves over time.